friends and colleagues. I'll cover interventions in coactation in the context of hypertension in the next few minutes. The mechanism of hypertension is multifactorial in coactation. They range from abnormalities of the aortic wall, including abnormalities in the microarchitecture, even growth factors, and residual gradients following surgical or interventional repair, alterations in the renin-angiotensin mechanism and resetting of the baroreceptors, and because of the presence of prosthetic non-aortic tissue, either stent or grafts following surgery, the compliance is reduced. All these contribute to hypertension. And this is the flow chart showing the various mechanisms, which means it is highly complex. So the long-term complications in a coactation are either after surgery or intervention or untreated, and they range from local complications, and after procedures there can be aneurysm, dissection, rupture, and in the associated bicuspid aortic wall they can have stenosis or regurgitation. The left ventricle can fail, systolic or diastolic dysfunction, they can have sudden death, and coronaries and other peripheral vasculature like cerebral can have problems. And as been mentioned, natural history is very poor. Median survival is only up to 3 decades, and by the 5th decade, 90% of the untreated coactation patients are no more. Majority of the causes of death are cardiac. Indications for treatment have been evolving, and it is generally presumed that a non-invasive pressure gradient between the upper and lower limb of 20 or above, or a peak-to-peak gradient of 20 or above, or in the presence of radiological evidence of coactation with significant collaterals, even with a reduced gradient, abnormal response to exercise in terms of blood pressure, significant LVH with hypertension, even if the gradient is low. These are indications. And the ESC has come up with guidelines. Those who have hypertensive patients with native or recoactation and gradient of more than 20 in invasive pressure monitoring, they are class 1. Those who have hypertension with more than 50% of the narrowing either by CT or angiogram with a peak to gradient less than 20 are class 2A. Class 2A is again normotensive with a gradient of more than 20. A lesser category of class 2B is those who are normotensive but lesser gradient. American Heart Association criteria are also almost similar. They also add a decreased LV systolic function or any presence of significant AR. The management is surgical, balloon or stenting, and the decision depends primarily on the age of the patient and the morphology or the anatomy. In neonates and infants, we can have critical coactation who are hypotensive and in shock, not hypertensive, and they preferred surgery. Surgery is also preferable in children, but balloon angioplasty is acceptable and stenting is upcoming with limited data. Adolescents and adults, stenting is preferable. And this is the flow chart showing the various modalities in terms of the age and the nature of the coactation. Balloon dilatation tears the media, the intima and the adjacent media, but its drawbacks is because of the same, it produces a recoil of the vessel and stenosis and also dissection aneurysm. The underlying fibrosis, as we mentioned, which predisposes to dissection and even rupture. These patients have sometimes cystic medial necrosis, and adults will have calcification, which are dangerous for simple balloon dilatation. This is an example of a balloon dilatation, and this baby, newborn, with critical coactation, and because the arterial puncture was considered dangerous because of the injury, it was crossed through a PFO, and antegrade balloon dilatation was done for the coactation. The technical aspects include 2 to 3 times, but not more than the diameter of the coactation, and it should not be more than the DTA at the diaphragm. Graded multiple short inflations are to be given with low pressure inflation. Immediate results are good, but restenosis occurs in about 1/3 of the patients. The younger the patient, higher the pre-dilatation gradient, and patients with a recurrent coactation develop restenosis faster. Aneurysms occur in some patients, and mechanism is because of the use of large balloons, longer inflation times, and because of the inherent abnormality of the aortic valve. So stenting has come up in a big way. It produces radial support to the vessel, reducing the velocity recoil, reducing aneurysm formation and aortic valve dissection. Stents are indicated. The hemodynamic indication remains similar as has been mentioned earlier, but the anatomical indications are long segment, associated hypoplasia of the isthmus, tortuosity, and recurrence along with aneurysm. These are indications for stent placement. Contraindications are a small child and those who are particularly small to receive a stent, which can be expected to adult size. Advantage of stenting, as we mentioned, as recoil and restenosis are prevented, aneurysm is less. The disadvantage is that reduced compliance and persistent hypertension because of the presence of a prosthetic material. These are the various stents available: closed cell, open cell, hybrid, and in India, Make in India, Zypher stent has also come up. These are the various dimensions available for the stents. Bare metal stents, stainless steel stents, open cell design, Mega, LD, these are all available. CP stent is also popular, but it is very costly. Andra stent is also there. It is a hybrid open cell, hybrid open closed cell. The procedure for stenting includes general anesthesia, various views which profiles the narrowing, passing of an extra stiff wire, placing it in either the subclavian or the ascending aorta. Adequate size balloon is chosen and a balloon in balloon technique is deployed. Here, an inner shorter balloon will inflate the inner part of the stent first, which will avoid potential complications, and we can, before the expansion of the outer 1 centimeter longer balloon, we can even reposition the stent. This is an example of a native coarctation. We can see the narrowing, the inner balloon, stent is placed, and the inner balloon is now expanded. There is sufficient time and opportunity to reposition the stent now. And now the outer balloon is being expanded, showing the final result. Procedure success is defined as less than 10 millimeter gradient and improvement in the anatomical diameter. Usually these patients continue to require antihypertensives maybe 1 to 4 months. We'll come to it briefly later. Results show that 98% acute success, complications in about 10% of the patients. Even children have successful procedure with stent. Freedom for reintervention is about 80% over the last 5 years. Weight to the child and a decrease in a smaller stent or predictors of a reintervention. Redilatation or reintervention usually is required when patients do not have proper expansion, either because they are small or because the neointimal proliferation causes restenosis. When there is growth of the patient producing relative restenosis, when there is redilatation, one can go up to 90 to 100% of the diameter. This is an example of a near total interruption where an antegrade and a retrograde access was taken, puncture was made, and with a electrocautery, a snare was used to pass the wire was taken through the snare, balloon was placed, and then a stent was placed, it was inflated. Very complex coarctations like those involving the arch can also be dilated. Complications of stent placement are aneurysms, but less. They usually cause at the edge of the stents. Neointimal proliferation, this is also less than in cases of balloon angioplasty. Aortic rupture and aneurysm formation are also small numbers. Stent migration is a dreaded complication as well as restenosis, but it can be tackled. Stent migration can be proximal as seen here, or while inflating it can be towards the distal aorta as seen in the second picture. Covered stents have come up. They are balloon expandable and self-expandable also come up recently. They are closed cell or open cell design. They tag the intimal flaps of the aortic wall and prevent tearing of the intima and reinforcing of the weakened areas, the preventing aneurysms. Indications are therefore patients who are judged to have high risk of these aortic wall complications, and they are electively in patients with complex anatomy, long segment, tortuous, and those who have restenosis, those who have PDA, and those who have recoarctation after a PTFE graft. Patients who have a stent fracture, those who have in-stent thrombus are also candidates for covered stent. Acute or chronic aortic valve injury, those who have aneurysm or dissection either as in during the procedure, it can be a bilateral procedure or on follow-up, and those who have genetic syndromes like Marfan's or Turner's, and those who are elderly are also candidates for covered stents. A few words to remember are that there is a risk of occlusion of the side branches, and the superiority of bare metal stents have not been proven. And they are not ideal for growing children, but because they cannot be expanded to the full size. Risk of spinal cord injury and also aberrant subclavian artery has to be excluded by CT before a covered stent is planned. The COAST-2 trial, where covered stents were used, showed a reintervention of 21%, and the predictors were smaller children and who have a higher pre-existing gradient. This is an example of a Cook stent which got fractured and a covered stent is placed. Comparison of surgical versus stent versus balloon angioplasty in coarctation shows that there is an improvement in systolic blood pressure in all, but stent and surgery are superior in terms of reduction of blood pressure compared to balloon angioplasty. So simple balloon angioplasty has no role to reduce hypertension. This is an interesting study which shows that whenever
Dr. Krishnamurthy, please, can you wind it up? Its time is up.
Whenever the incidence of stent failure is more than 39%, the initial cost of stent is better than surgery. They are also useful in children, and covered versus bare metal stents were compared. It shows that those who have only high risk, only there are indications for bare metal stents. The long-term effects of intervention of hypertension shows that those who are smaller, the younger age intervention, they respond better in terms of hypertension. The residual hypertension is present, even LVH is present in spite of drugs in certain patients, and they are usually the older patients. Thank you.